What's up, Ninja Nerds? In this video today, we're going to be talking about ischemic heart disease, also known as coronary artery disease. This is a very interesting disease, very high yield for your USMLE Step 2, so we definitely got to go through this and really understand it. So when we talk about ischemic heart disease, it's basically atherosclerotic plaques that usually develop within the coronary vessels. Okay, the coronary vessels are the vessels that supply oxygenated blood to the myocardium of the heart, the contractile, the depolarizing types of tissue of the heart. So we need that coronary blood flow to be able to give oxygen to those myocardial cells. But in these patients with ischemic heart disease, there's a decreased delivery of oxygen. And the most common cause by far is a reduction in blood flow or complete loss of blood flow to the myocardium due to atherosclerosis, fatty plaques that are developing within the vessel walls. There is other less common causes of a decreased oxygen supply, and we'll briefly talk about that, but I really want you guys to remember atherosclerosis is the most common cause of a decreased oxygen supply to the myocardium of the heart. Boom, shakalaka. Now, when we talk about atherosclerosis, if we were to look here, here is the myocardium, right? So we have here, this is the lumen of the right ventricle, the lumen of the left ventricle. This is the wall of the left ventricle, interventricular septum, and then the wall of the right ventricle. We have a blood vessel, and this blood vessel is supposed to be taking and delivering oxygen and nutrients to the myocardium of the heart. And then obviously it would place its CO2 and waste products into the blood to take away from it. Now, if someone has ischemic heart disease, they get this big fat goober that's blocking the blood flow distal there. So the blood flow will move normally here, and then, ooh, they gotta squeeze through this little area here. And so because of that, there's less oxygen that's delivered to the myocardium, decreased oxygen supply, and therefore there'll also be less CO2 that's being picked up, less waste product being picked up. Why is that a problem? If this muscle can't get its oxygen, it can't make ATP. If it can't make ATP, it can't use that ATP to initiate contraction, to power all of those pumps that allow for the depolarization of those muscles. And the muscle will start to fail. So, what I want you guys to remember is what are the things that increase the risk of these plaques forming within the vessels? Guess what? Mnemonic, bad heart. Right? B, BMI greater than or equal to 30. So you can think about those individuals who are obese. Next thing, A, age. Age greater than or equal to 65. Now this is important because this is a non-modifiable risk factor. You can't change your age, but you can potentially lose weight, eat healthier. So obesity is a modifiable risk factor. Diabetes. This is actually probably one of the big ones that I really don't want you guys to forget. If you guys forget some of these, that's okay, but this is the big one because it's the worst type of risk factor for ischemic heart disease or coronary artery disease. Hypertension is the most common risk factor for patients with ischemic heart disease. Alcohol abuse can also increase the risk. It's a minor risk factor, but it is a risk factor for coronary artery disease. And then to help out with the mnemonic, an increase in LDL and a decrease in HDL. This is also called hyperlipidemia. An increase in this LDL lipoproteins, increased deposition of fat and cholesterol within the vessel wall. Decrease in HDL, decreased removal of cholesterol and fat from the vessel wall. This is going to increase the formation of those plaques. Okay? The next one here is another type of non-modifiable risk factor. If you have first-degree relatives who have had coronary artery disease, they passed away of a heart attack or myocardial infarction, that is a risk factor for ischemic heart disease. And last but not least, tobacco use. Smoking has been shown to be able to significantly increase the endothelial injury and increase the risk of plaque formation. But again, two that I need you to not forget is diabetes and hypertension. Now, we come back to this whole issue of the atherosclerosis decreasing the oxygen supply, right? So the most common cause that you guys can't forget is atherosclerosis. Is there any less common causes that we don't need to spend a ton of time thinking about, but potentially? What if it wasn't an atherosclerotic plaque? What if it was an embolus? So some type of embolus could definitely potentially cause a problem. What's another one besides an embolus? We want to think about some inflammation of the vessel. If that vessel gets really inflamed, it can actually narrow the vessel lumen. And last but not least, if there's any type of vasospasm. And we'll talk about this. But again, these are very decreased, likelihood. This is the big one that I need you guys to remember. Now, here's the thing. If you have a decreased oxygen supply, that's obviously a bad problem because less oxygen means less ATP, less myocardial activity. But if there's still some oxygen getting to the myocardium, it might do okay. The problem is when the myocardium has a high demand. In other words, there is an increased consumption of oxygen. And I'm consuming so much oxygen that I need more to continue to function at that high rate. So what if the myocardium is beating really fast and it's having to contract really fast? What's that called? Tachycardia. So in patients who are tachycardic, they have a high heart rate. That would increase their oxygen consumption. What if they had a very thick myocardium, where they had so many myocardial cells and you have to supply a lot of oxygen to those myocardial cells? What is that condition when the myocardium is really, really thick? We call that left ventricular hypertrophy. You see that in patients with hypertension, patients with aortic stenosis, patients with hypertrophic obstructive cardiomyopathies. But you know what else it could be? What if I just go work out? It's a simple thing, right? Exercise, exertion. When you exert yourself, you obviously increase the contractility of your myocardium, you increase the heart rate. These are things that are going to cause an increase in oxygen demand. And if the supply is low and the demand is high, there's a mismatch. And that problem can lead to ischemia, and if not reversed, the cells can die and they can infarct. And that is a no bueno. So we have an idea now about this atherosclerotic plaques. We know about these things and mismatches. We got to talk about the categories of ischemic heart disease. So we got a couple different types here. First one is stable angina. Angina is a type of chest pain. It's specifically related to, again, ischemic heart disease. It's this substernal chest pain that feels squeezing, it's tight, it's choking like an elephant sitting on the chest. But if it's a stable angina, what happens is they have a very stable plaque. They have that fatty plaque, and you see this blue kind of like line here? They have a very strong fibrous cap that prevents this thing from rupturing, which is a good thing. But the problem is that this really narrows the lumen to almost greater than or equal to 70% occlusion of the blood flow. That's a decrease in oxygen supply, and that can lead to chest pain. But the chest pain with these patients is with exertion. So they have to work hard. They have to develop a increase in demand enough that the oxygen supply isn't enough, and they develop chest pain when they're exerting themselves. But it actually can chill out if they sit down and they rest and they stop having a high oxygen demand. These patients develop ischemia, though. Okay, so that's a decreased oxygen supply. And so what happens is, these blood vessels, imagine they have like feeders coming off of them that are supplying these parts of the myocardium. The areas that are going to be most affected from the epicardial vessels to the endocardium is as the blood goes farther away, less oxygen gets supplied, less blood. So these areas right here can become ischemic. And so we call that subendocardial ischemia, but the cells aren't dead. So that's a big thing here for stable angina. Subendocardial ischemia due to about greater than or equal to 70% occlusion of the vessel, chest pain with exertion, they have to have a high demand. Unstable angina, they actually have an unstable plaque. What the heck that mean? That means that this fibrous cap isn't strong and it can rupture. And it can expose that kind of fatty material within the center of it. And that platelets be loving that. And so they stick to it. And when the platelets stick to it, it can form a thrombus on top of the plaque and occlude the blood even more than 70%. How much, you say, Zach? Almost greater than or equal to 90%. We call it a near total occlusion because it's near 100, but it isn't. So greater than or equal to 90%. Now, in this case, very little blood flow is getting by. There's a definite decrease in oxygen supply. But because there's way less oxygen supply in comparison here, it doesn't require much demand. If you definitely go and exert yourself, oh my gosh, the ischemia is going to get really bad. But these patients can have chest pain at rest because of how significant the occlusion is. So that's one of the big differences here. And again, going back to this is the vessel. Imagine the feeders coming off of this. Which vessel component would be the most susceptible to ischemia? The farther you go down into the myocardium. So they would have subendocardial ischemia, no infarction. Just like stable angina, just the degree of occlusion is increased. This is a stable plaque, this is a ruptured plaque. This occurs with exertion. This one will occur at rest, but it can get much worse with exertion. All right, the next one that we have to talk about is what's called subendocardial infarcts. You're like, man, I ain't never heard of it before. Guess what? We don't really call it this. We call this an STEMI. That's really what we call it. But we have to understand what that means a little bit later. For right now, just trust me that a subendocardial infarct is an STEMI, a non-ST segment elevation myocardial infarction. So with this, the pathophysiology-wise, again, it's all plaquey, all that atherosclerosis, but it's an unstable plaque. That ruptures, the fibrous cap isn't stable, exposes the underlying fat material. Platelets be like, and they stick to this and actually cause a thrombus to form. Almost a near total occlusion. How much you say, Zach? Greater than or equal to 90%. It's a near total, but not completely total. In this situation, though, the difference between a NSTEMI or subendocardial infarct from unstable angina is that the actual blood flow is reduced enough that these feeders are significantly having a reduction of oxygen to the tissues, that the cells actually die. The ischemia is too long. Usually it's getting to the point of where it's greater than or equal to 30 minutes of ischemia that hasn't been reversed. And then the cells begin to die. So there is infarction of the tissue, okay? And again, you usually see that more with like greater than or equal to 30 minutes of irreversible or unreversed ischemia. Okay, now the big difference here is because they have such a significant occlusion, this chest pain can occur at rest. They don't have to work really hard, get their heart rate up, exercise, increase their blood pressure to really get to the point to have them have such a high demand. If you get them to run around, oh my gosh, that chest pain is going to get bad, but they can have chest pain at rest. That's a big thing. So again, sounds similar to unstable angina, right? That's because it actually it's in a category we'll talk about at the end, but the big difference is ischemia, infarction. This one, usually the infarction has gone for a long period of time. The ischemia has gone for a long period of time, greater than or equal to 30 minutes. That has led to an infarction. All right, next one, transmural infarct. You're like, what the heck that mean, man? I ain't never heard this. That's because we don't call it this. We call it a STEMI, but we got to understand the pathophysiology, ninja nerds. So what happens is, again, it's an unstable plaque. The fibrous cap is not stable. It ruptures, it fissures, it ulcerates, it exposes that inner cheesy fatty material. Platelets be like, oh, I'm going to jack this up. And he goes and plugs up this entire lumen. Plugs it up how much, you say? 100%, total occlusion. Ain't no blood flow getting through that. Because of that, imagine this. It doesn't matter if you decide to go on a run with this total occlusion. It doesn't matter if you decide to sit still with this total occlusion. No matter what, there is a complete loss of supply of oxygen. This entire myocardium that's being served by that vessel will have no oxygen delivered, that the entire myocardium will be affected. And that's where we get this term transmural. It's from the endocardial portion all the way to the epicardial portion. So this entire area will infarct. And this can produce chest pain at rest, but you better believe that it definitely produced chest pain, if even worse thing, intensified severity, high frequency chest pain if you exert yourself. Okay? So we have some understandings of the differences in types of angina and particularly NSTEMI and STEMI. What I want you guys to remember is there's a very specific terminology to what's called an NSTEMI, a STEMI, and unstable angina. These three together are grouped under the category, and we're going to just write it up here, of what's called acute coronary syndrome, ACS. Again, that's NSTEMI, STEMI, and unstable angina. The last type of category or variant of ischemic heart disease, even though it's technically not a part of it, but we have to understand it for your USMLE Step 2, is what's called Prinzmetal's or vasospastic angina. You're probably going to at least get one question on this on your exam. And what we know about this condition is it has nothing to do with atherosclerosis. They may have incidental findings, but it is not the reason for their chest pain. Remember what I told you? That when it's a reduction in oxygen supply, it could be primarily atherosclerosis, embolus, vasculitis, and what was the last one? Vasospasm. This is a vasospastic angina, and the big difference, when you look at the clinical vignette, if you have patients who are diabetic, obese, alcohol use, they're greater than or equal to 65, have a family history, hyperlipidemia, all of those things, that puts them more in this category. But if they're a young female who has been using cocaine, methamphetamines, smokes, drinks alcohol, doesn't have a lot of cardiovascular risk factors, or has a history of migraines or Raynaud's, and they take triptans for migraines like sumatriptan, this is a cue to think, oh man, this could be vasospastic angina. The other thing is, not only is it a young female with not many cardiovascular risk factors, but smoking, alcohol, cocaine, triptans, but it actually seems to happen at night, usually around midnight, maybe in the morning. They develop this chest pain. And this chest pain is actually due to vasoconstriction of the coronary vessels. So imagine this coronary vessels decides to clamp down, squeeze, narrow the lumen. If I narrow the lumen enough, I can actually cause ischemia to this entire territory. And that's pretty significant, and that's called transmural ischemia. Transmural ischemia. Now, this is important, and we're going to briefly talk about this a little bit later, but I want to get this right here because this is where it's good to get this in the beginning of the video. When you see this on the exam, the patient will have what's called ST segment elevation on their EKG. Their troponins, which is a marker of destruction, infarction, not ischemia, infarction, would be indicative of troponin leaks. You'd see an infarction. Is there infarction? No, there's just ischemia, so their troponins would be negative, their ST segments will be elevated. But here's the big thing. It can be reproduced by what's giving them medications like acetylcholine or ergonavine. And what acetylcholine and ergonavine do is they bind onto little receptors and cause the vessels to vasoconstrict, causing the ST segments to go up. The other thing you can do is you can have them hyperventilate, and that may also cause their ST segments to go up. But big thing to remember, ST segment elevation reproduced with acetylcholine and ergonavine, tropes negative, female, young, no cardiovascular risk factors particularly, smoking, alcohol, cocaine, triptans. How do we treat them? We give them a calcium channel blocker to dilate these vessels. We can give them nitroglycerin to dilate the vessels. Big thing to do is avoid beta blockers. Why? You know, on your vessels in the coronary system, we have beta 2 receptors and alpha 1 receptors. Beta 2 receptors want to dilate. Alpha 1 receptors want to constrict. If you give someone a beta blocker, you block the dilation. Now what do they only have? Alpha 1 activity. And so whenever anything happens, the alpha 1 receptors are wide open for any kind of like epinephrine, norepinephrine, and that'll cause vasoconstriction to worsen. So stay away from beta blockers in these patients. That covers the components of causes and pathophys. Let's start getting into the components of clinical features, complications of ischemic heart disease. All right, so now we got to talk about the clinical features and particular complications that can arise in patients with ischemic heart disease. So obviously we said that this is atherosclerotic plaque related, right? And now what happens is the primary symptom that you want to think about on your actual question in the vignettes is a patient presenting with chest pain. But we got to really kind of dig into this and really understand the actual chest pain. So, you know, when you're taking your history, you should always use the OPQRST approach within your HPI. So you ask onset. So tell me a little bit about your chest pain. The chest pain that you're having, when did it start? How long have you had it? Usually, one of the ways that can help you is have they had chest pain for like less than 10 minutes? Because usually patients with like a stable angina, it's more likely to be like 5 to 10 minutes. Whereas patients with an acute coronary syndrome, unstable angina, NSTEMI, and STEMI, tend to be a little bit longer, like greater than 10 minutes. And so that's one thing to think about to help you to realize that. The second thing is P. Are there any palliative or provocative factors? Anything make it better? Anything make it worse? And particularly patients who have stable angina, they tend to have chest pain that gets worse when they're exerting themselves. Whereas patients who have an unstable angina, NSTEMI or STEMI, the acute coronary syndrome, theirs tend to be at rest. But it can definitely get intensified, more frequent, and more severe with exertion. Another big cue here that may show up on your exam is that it improves with nitroglycerin. This is very common specifically for anginal chest pain. So that's another big thing. Usually for stable angina, it's going to be worse with exertion. For your acute coronaries, it's going to be usually at rest. And again, for the stable angina more specifically, it usually relieves with nitro, where the acute coronaries, it can be variable. The next thing is the quality. This is a very big thing. What does it feel like? Stabbing, burning? Does it feel like pressure, squeezing, sharp? What does it feel like? And usually these patients, it's more of a squeezing, a pressure, a vice grip type of sensation, feeling like an elephant is sitting on your chest type of sensation. So that's something to think about. The next thing is, does it radiate anywhere? And usually these patients' chest pain may radiate into their left arm, it may radiate into the left neck, and it may even radiate into the left jaw. Another big cue is if a patient has epigastric pain right here, don't ever conclude that it's not cardiac related, because sometimes inferior STEMIs can present with epigastric abdominal pain. So that's another one to think about as well. Next thing is severity, and this can be variable from patient to patient. But the next thing is T. How long has this been constant, has been intermittent? That's another important thing, because usually in patients with these types of ischemic heart disease, it's more of a constant type of pain. Okay, so that's big things to think about with this type of anginal chest pain. Now, here's the big thing that may come up on your exam, and you have to realize that. And maybe it doesn't come up on your exam, but it's something to be very, very cautious about in real life. Patients who are diabetic because they have neuropathy, and I'll explain how this mechanism works, chest pain, but diabetics, they can have neuropathy of particular nerves. Remember that. Elderly, as they get older, certain nerves actually start functioning well, and those who have had a post-heart transplant, there's an alteration within the nerve signaling as well. These patients may not develop chest pain at all, and they may have an atypical type of chest pain presentation. In other words, they can have a silent MI. They could be having an MI without any chest pain. Think about this in diabetics, elderly, and post-heart transplant patients. Now, let's understand a little bit about this chest pain. As you know, the heart has particular types of autonomic fibers, if you will, that it takes sensations from the heart, and it can take these sensations from the heart and into the spinal cord, right? Usually the cervical thoracic region of the spinal cord, somewhere along C8 to T4 region of the spinal cord here. And what happens is in the spinal cord, there is special like sensory neurons in that dorsal gray horn there, okay? So these are sensations coming from the heart. Now, the other thing to remember is that you also have other fibers that converge on that same sensory neuron. Sensory fibers from the left arm, sensory fibers from the left neck, sensory fibers from the left jaw. These also are going to be taking sensations and dropping this off on the same sensory neuron in the dorsal column. So, posterior gray horn, sorry. So if someone develops an infarct or ischemia of the heart, it may activate some firing of these neurons that travel down this nerve into the posterior gray horn. At the same time, these nerve fibers coming from the sensory fibers of the left arm, the neck, and the jaw may also be carrying action potentials in synapse on the same neuron. The problem with that is that these fibers will get sent over and up into the brain, and the brain will interpret that chest pain is coming from also referred areas like the left side of the neck, the left side of the jaw, and the left arm. So that's some of the important things to think about here as to how this works. So that's kind of a little bit on the pathophysiology, nothing crazy though. What you also need to remember is when this happens, when this kind of pathway occurs, sometimes you can develop autonomic types of reflexes in response to this. Your autonomic nervous system can become activated and produce autonomic effects, and these are big things to think about. If a patient has chest pain in combination with nausea, vomiting, diaphoresis, syncope, or also any type of sense of impending doom, that is very, very concerning for anginal chest pain, ischemic type of etiology. Be thinking about that. So big things to take away here. Understand how to OPQRST the chest pain, understanding anginal chest pain, understanding the atypical types, the silent types, and again, understanding a little bit about the mechanism of chest pain, but remembering any autonomic effects should also cue you off to think about ischemic chest pain. All right, so now we need to talk about right ventricular MI versus left ventricular MI, because this is a question that may come up in your exam. It's really honestly understanding the difference between right-sided heart failure and left-sided heart failure. Really, that's really what it is. Because let's think about it. If your right ventricle, like you have a right coronary artery that gets really clogged up and your right ventricle stops working, what does the right ventricle do? All right, well, let's first think about this. The right ventricle has to receive blood from the superior vena cava into the right atrium, then down into the right ventricle, or it has to get blood from the inferior vena cava into the right atrium and then into the right ventricle, right? If the right ventricle stops working and it's not pumping blood up, it's going to cause a backflow into these two channels. So what is it going to do? If it pumps up the superior vena cava, it'll back up into the superior vena cava, the brachiocephalix, and then into the jugular veins. And those puppies will get all kind of puffed up and distended. And we call that jugular venous distension. So that could be one particular sign. If it backs up into the inferior vena cava, it can go into the abdomen, and near the liver, it can cause hepatomegaly, it can cause ascites, and it can even move its way down into the lower extremities and cause lower extremity edema. So that's another thing to think about, is not only JVD, but they may have edema, particularly of their lower extremities, okay? And they may have some, hepatomegaly and ascites potentially. But these are the two big things to think about. So edema of the lower extremities, JVD is one thing. Here's another one. Now, when the right ventricle receives blood, it's supposed to pump blood out into the lungs, and then eventually out from the lungs, it comes back to the left side of the heart. If there's less blood that's getting pumped out of the right ventricle, that means less blood is going to the left side of the heart. What is that called what is the volume that is going into the heart whenever it's during the relaxation phase? That's called the preload, right? So in this case, less blood is going to go from the right ventricle to the left ventricle, so the left ventricle will get less blood. So the preload is going to drop in the left ventricle. If preload goes down, what does that do to your stroke volume? It drops your stroke volume. If stroke volume goes down, what does it do to your cardiac output? It drops your cardiac output. If your cardiac output goes down, what does that do? It lowers your blood pressure. So another thing is these patients can also develop hypotension. Not as severe as the left-sided heart failure, but it can definitely happen. Another thing is because the left side of the heart isn't having a problem, their lungs are usually clear. They have no problem with their lungs. So the lungs are clear. There's no backing up of fluid or blood into the actual lungs. That's another big thing. So remember, JVD, edema of the lower extremities, hypotension, the lungs are clear. But one more thing. The right coronary artery also can give blood flow to the SA node and to the AV node. If these get knocked out, you affect the conduction. If you affect the conduction of the SA node to the AV node, very specifically though the AV node, that's less action potentials that'll get carried through the AV node. There could be a block there. So this may lead to a decrease in heart rate that may present as maybe just sinus bradycardia, or it may present as an AV block. And depending upon the severity, it may be a first degree, a second degree, a third degree. It really depends upon the severity of the AV dysfunction. But please don't forget these things for right ventricular MI, okay? Now, the last thing is that, again, the right ventricular MI, it's very important to remember that you want to be very careful when we're talking about this later, about a very specific drug that you probably want to avoid giving in these patients, because these patients are very preload dependent. They depend upon volume to come into the heart. So if you give them drugs that drop their preload, it can really drop people's blood pressure. Think about that. It'll come back a little bit later. All right, that's right ventricular MI. The left ventricular MI is a very important one to remember. Again, it's just left-sided heart failure, guys, right? So a patient with left ventricular heart failure, again, here's the left ventricle. It's all jacked up. It's not working. It's not contracting well. Okay, who does the left ventricle get blood from? Well, it comes back from the pulmonary circulation into the left atrium, and from the left atrium down into the left ventricles. If the left ventricle isn't working, blood will start to back up because less blood is going to be leaving the ventricle and into the aorta. And so because of that, the blood will start backing up into the pulmonary vessels, into the pulmonary circulation, and leak out around the pulmonary capillaries. And it'll cause edema within the lungs. And we call this pulmonary edema. And this can definitely present with some shortness of breath, difficulty with breathing. The other thing that's really important here is that whenever this left ventricle stops functioning well, not only can they present with pulmonary edema, but also, remember, less blood is being ejected. If this is dysfunctional, it's not going to contract as much blood out into the aorta and into the systemic circulation. So there is a decrease in the ejection fraction, or a decrease in the ability of the amount of blood that they can get out. And so this can lead to hypotension. Okay? That's big things to remember. So they can develop hypotension, they can develop pulmonary edema. One more thing is that whenever these hearts get kind of infarcted, they can somewhat become fibrotic. Another thing that can happen is the ventricles are really stiff. And when the ventricles are really stiff, whenever blood comes in from the atria into the ventricles, it makes a noise because the ventricles don't want to actually allow for that blood to come in. It makes a really interesting heart noise that is very high yield on your USMLE Step 2. And this is called an S4 heart sound. Please don't forget that. That may come up as well. Okay, so we have understanding the differences really between a right ventricular MI and a left ventricular MI. The next thing that we have to understand here, one last thing actually, I apologize. In a patient with a left ventricular MI, they create a reflexive reaction. Don't want to forget this one. This one was like that bradycardia kind of thing, AV block. And left ventricular MIs, because they become hypotensive, that hypotension triggers a reflex. They're not getting as much blood out. Their blood pressure drops. Our autonomic nervous system tries to increase our heart rate so that we can increase our cardiac output and try to increase our blood pressure. So other signs for these patients is they may have what's called a reflex tachycardia. And also if they have hypotension, way more than right-sided heart failure, they're not going to perfuse particular organs. And so their skin may be cold, it may be mottled, they may have kind of a decreased, kind of like a pale or pallorish type of hue. And so that may be something else to think about. Mottled, pale, cold extremities due to a decreased perfusion because of low blood pressure. So don't forget that as well. Okay, that's my end of the soapbox for these MI components. Now let's talk about the complications, which I can't stress enough. This is super high yield for your USMLE Step 2. All right, so we really need to understand the complications of ischemic heart disease, very specifically if someone has a myocardial infarction. So an NSTEMI, STEMI, but way more specifically, a STEMI, okay? If someone has a myocardial infarction in general, what happens is this area of infarction, the tissue's permeability, the cell's permeability decreases. Imagine I took one of these like cells and I just kind of zoomed in on them. Imagine these cells being like more permeable. And the problem is if they're more permeable, they're more allowing for things like calcium, sodium, things like that to load into them, cations. And when these cations load into these cells, it makes them depolarize and fire unnecessarily and out of the normal synchronous order. If that happens, if this area here starts to fire and generate these electrical potentials, that it gets to the point where the ventricles start beating at that rate, depending upon that area, what is that called? This can lead to what's called PVCs. So it may first start off with just PVCs, but then these PVCs can progress into full-blown VTAC, and then VTAC can progress into full-blown VFib. And when someone goes into ventricular fibrillation, it can quickly lead to sudden cardiac death. And so that's one of the big things to think about within the first 24 hours after a myocardial infarction, is sudden cardiac death due to very nasty ventricular arrhythmias. Okay. The second thing to remember within the first 24 hours is if you develop a significant infarct, let's say particularly the left ventricle is more common and more significant. So if you have like an LAD, a left anterior descending artery occlusion, we'll talk about that in a second, of the left ventricle, and the left ventricle becomes all jacked up, it's not going to be able to push blood out into the systemic circulation. So what do we say happens here? It's pretty much left ventricular MI. What happens? They can become hypotensive. If they become hypotensive, they don't perfuse their extremities. So I just want you to remember cold extremities, okay? They become hypotensive, potentially go into a shock state. What is that called if it's shock due to the heart being a problem? Cardiogenic shock. So this eventually could somewhat progress into a shock state called a cardiogenic shock. If the left ventricle stops working, blood starts backing up into the pulmonary circulation, leading to flash pulmonary edema. What do we call this? Flash pulmonary edema, where they develop a very acute onset shortness of breath, hypoxia, and so these are very significant problems as well. And they can also develop, again, that reflexive tachycardia, where their heart rate just starts really going out of control to be able to maintain a decent cardiac output. And so that's another thing to be thinking about. So these are the things to remember within the first 24 hours: sudden cardiac death, as well as acute decompensated heart failure or cardiogenic shock. Okay, this is a big one for your exams. Within the next 24 hours to 3 days, so 1 day to 3 days, you want to remember just rupture syndromes. So areas can rupture. Which areas? Okay. First thing that you want to remember is, you see this we said is the right ventricular wall, left ventricular wall, and this right here is called the interventricular septum. Sometimes if you infarct this area, let's say that you infarcted this interventricular septum. After it infarcts, the tissue can start becoming weak, fragile, and susceptible to just rupturing. If that ruptures, I can now push blood. Which one's a high pressure system? The left ventricle or the right ventricle? The left ventricle pushes more blood. It's got to push it from our heart to our little toes. So it has to be a higher pressure system. And so this can push blood from the left ventricle into the right ventricle. What is that called? A ventricular septal defect. And so one of the things that can happen here is they can develop what's called a ventricular septal defect due to a interventricular septal rupture. That's an important thing. They may have a murmur, and they may have mixed oxygenation. And so that's another big thing to remember. So again, they may have a murmur. Sometimes we use the term holosystolic murmur. And they may have a mixed venous oxygenation. Okay, their O2 within the actual venous circuit would be higher than usual. Okay? Another thing, here's the scary one. What if you develop an infarct of this left ventricle area? it becomes weak, it becomes, very, very soft granulation tissue and very susceptible to rupturing. And then this bad boy ruptures, and I can now have blood going from my left ventricle right into my pericardial cavity. So this is called a free wall rupture. So sometimes they can develop what's called a free wall rupture. And then from there, the problem with that is I can extend blood right into my pericardial cavity. What the heck would that do? Blood filling into the pericardial cavity could quickly lead to a hemopericardium and leading into cardiac tamponade. And so this could quickly lead to cardiac tamponade. And it's important for you guys to remember Beck's triad for cardiac tamponade. What is that? Hypotension, JVD, and decreased or muffled heart sounds. That could happen if a patient has a MI and 1 to 3 days later they have signs of cardiac tamponade. That's the next one, all right? One more. Coming off of the ventricles, there's these little muscles that kind of extend outwards like this. And their design is they connect to these little collagen, kind of like connective tissue here. Imagine these little cords. And these cords, what they do is they connect to things like valves, right? In this case, if it was like, let's say there was a valve like right here. Let's say here we had 2 papillary muscles here. There's a papillary muscle right here. And then again, these papillary muscles had their collagen kind of connecting to these valves, okay? Imagine that you had a infarct developing within the papillary muscle. And what happens is the granulation tissue forms, it gets weak, and then you rupture the papillary muscle right off of that wall. These papillary muscles hold onto the chordae tendineae and anchor that mitral valve down. If you lose that papillary muscle, the chordae tendineae can't hold the mitral valve down, and the mitral valve will start kind of blowing back up into the left atrium. So then this valve will just start blowing up into the left atrium. What is that called when blood goes from the left ventricle back up into the left atrium during systole? That's called a mitral regurgitation due to papillary muscle rupture. So you can develop what's called papillary rupture. And the big thing to think about with this one is this will definitely produce a murmur, what's called a mitral regurgitation murmur. So this is a holosystolic murmur. And again, they also could develop signs of pulmonary edema, hypotension. Very, very problematic issue there. The last thing to think about, I'm not super concerned if you remember this one, but it is something to think about here, is that sometimes when this blood, you have that free wall rupture, blood can kind of accumulate in what looks like an aneurysmal kind of form outside of the left ventricle. This kind of blood can form around it, and it's kind of formed by the pericardium. It's not a true aneurysm, but it looks like an aneurysm. And we can actually see this as well. The last one, so we have VSD, the ventricular septal defect due to a ventricular wall rupture, interventricular. 2 is the free wall rupture. 3 is the papillary rupture. The 4th thing is they can develop what's called a left ventricular pseudo aneurysm. And all that means is that what happens is that you kind of get like this walled off area by the pericardium. The pericardium kind of forms like this little walled off area like this. Imagine it kind of forms like this little walled off area here. And you start getting this kind of like area where the blood can kind of sit in here. And that's a problem. You get like this little pseudo-aneurysmal area. And when that happens, that's a quick area for clots to form. Because now you have a little nidus, a little location where blood isn't flowing correctly, and then that can allow for a stasis to form, a clot formation to occur. And these left ventricular pseudoaneurysms can increase the risk of thrombi. Okay? What's called a mural thrombus. So that's an important thing to remember. Okay, so we got sudden cardiac death, acute decompensated heart failure in the first day, 1 to 3 days, rupture syndromes. What about 3 days to 14 days? Okay, within this one, it's really not that hard. Thank goodness it's an easy one. It's pericarditis. Okay? So what I want you guys to remember is, let's say here you infarcted this part of the left ventricle. This is going to create kind of an immune reaction. All right? Well, there's going to be inflammation, I should say. An inflammatory reaction, because white blood cells like neutrophils and macrophages will come to this area to clean up all of that debris. And what happens is that inflammation from the immune cells coming to that area to clean up the debris leads to kind of a local inflammatory reaction. And that local inflammatory reaction will kind of inflame the nearby pericardium. So it produces this kind of localized inflammation. And that's called pericarditis. So they will actually present with kind of like a chest pain, but it tends to be sharp, and it tends to be particularly sometimes positional. So sometimes they have it can be somewhat positional. The other thing with this one is sometimes it may produce what's called a friction rub. So because of the inflammation of the pericardium, when you listen to the lungs, it may sound like kind of Velcro being separated from one another. And then with these patients with pericarditis, sometimes if you get enough inflammation, it can increase the formation of fluid and lead to pericardial effusions. So these are things to remember as well. Okay, last but not least here is when we go from 3 days to 14 days, we get the last one, which is 14 days to 1 month. This is the last one. Now here's what happens is, let's say that this area here of the left ventricle is infarcted, right? When it infarcts, it gets like this really soft granulation tissue. Then what happens is some fibrous tissue forms. When that fibrous tissue forms, it leads to this kind of like really interesting thing here, where you get this fibrous tissue that actually starts to kind of balloon out here. So you get this kind of like fibrous tissue that balloons out here. And you get this thing called a left ventricular aneurysm. This is a true kind of like aneurysm here. And this is kind of like the pseudoaneurysm, but in this situation, it's usually, again, going to be occurring a lot later, usually 14 days to a month after the initial myocardial infarction. But with this one, again, you got to remember, there is a susceptibility for this to rupture. Okay, so if it did rupture, it could produce a very significant bleed. Usually this fibrous tissue is a little bit stronger though, so there's a lower likelihood of rupture. What is a very high risk at this point is, again, look what can happen. This area isn't contracting. If this area isn't contracting, it's not moving blood very well through this portion of that left ventricle. What does Virchow's triad say? If there's any stasis, if there's any hypercoagulability, if there's endothelial dysfunction or injury, that's an increased risk for forming clots. Well, there's going to be endothelial injury there, but it's more likely stasis that's the problem. And that stasis is going to lead to clot formation that can form here. And you can easily develop a thrombus. And again, this left ventricular aneurysm, it increases the risk of what's called mural thrombi. And if we break off pieces of that thrombi, that can go and embolize. And so that increases the risk of emboli to the brain, emboli to the spleen, emboli to the kidney, emboli to the lower extremities, emboli to the mesenteric circulation. And they can lead to a lot of embolic phenomenon. So that's a big thing to think about. The last one, which is also really interesting, though we don't have a complete reason as to why this happens, but with these patients, they also, again, they develop an infarct of like the ventricle. And what happens is this creates this immune reaction, which we don't understand how it happens, but our immune system develops antibodies. And these antibodies that are made against these kind of inflammatory reactions that are occurring here in the myocardium as a repair process, these antibodies like to go and attack the pericardium. And it produces an inflammation of the pericardium. Not within this time period of 3 days to 14 days, 14 days to months later. This can produce a chest pain, pericarditis type of problem that is, again, occurring later, but it's usually due to some type of underlying unknown immune reaction. And that is the last thing that I want you guys to know about the complications. Now that we've done that, let's start moving right into the diagnosis of ischemic heart disease. All right, engineers, let's now talk about the diagnosis of ischemic heart disease. Now, When we talk about ischemic heart disease, we've obviously have to go through each one of the ones that we talked about. So stable angina, Prinz-Metals, and the acute coronary syndromes, right? So going back a little bit to the pathophysiology, remember stable angina? There was subendocardial ischemia. That's very important. So what we want to know is if we got a 12-lead EKG, which is pretty much the most important test that you should remember for ischemic heart disease, what would it show? Well, the big thing that you would want to know is that it would show no ST segment elevation. It may have other non-specific ST T-wave changes, but it wouldn't be anything obvious. So there would be no ST segment elevation, maybe some ST depression and T-wave inversions and Q-waves, but again, nothing specific. That's the first thing. The second thing is that one of the other tests that you should have for a patient with ischemic chest pain is not just the 12-lead EKG, but you should order biomarkers, troponins, and sometimes CKMB. In these patients, do they have infarction? No, it's ischemia. So is there cell destruction? No. Are they going to leak out troponins and CKMB? No. So there will be no biomarkers like troponins or CKMB. That's the first thing. For Prinz-Metals angina, vasospastic angina, remember what I told you, there's transmural ischemia. That will produce ST segment elevation that is transient, can be reproduced by acetylcholine or ergonovine. But will the tropes be positive and CKMB be positive? No, because there is ischemia, no infarction. Okay? Now remember, what in the world is these three things called? Unstable angina, NSTEMI, and STEMI are all a part of the group of acute coronary syndrome. Okay? Unstable angina, NSTEMI, STEMI, they're a part of the group of acute coronary syndrome. We should be able to differentiate these. These are the most severe ones of ischemic heart disease. Unstable angina, it's subendocardial ischemia, no infarct. But if you got their 12-lead EKG, it may show signs of ST depression, T-wave inversions, but no ST segment elevation. Would there be any infarction here? No, only ischemia. So would the tropes or the CKM be elevated? No, they would be negative. So that's a big, big thing here. The next thing is NSTEMI. NSTEMI is a subendocardial infarct. That means there's actually tissue destruction. There will be ST segment depressions and T-wave inversions and no ST segment elevation. Is there tissue destruction? Yes, there's an infarct. Will you leak troponins and CKMB out into the blood? Yes. So the troponins and the CKMB will be positive or elevated in NSTEMIs. That is the big difference between unstable angina and NSTEMI. Troponins are positive for NSTEMI, negative for unstable angina, but they both can have ST depressions and T-wave inversions, no ST segment elevation. Okay, last one is STEMI. STEMI, it's a transmural infarct. If you get the 12-lead EKG, it'll show ST segment elevation. If you get the troponins, is there an infarct? Yes, there's tissue destruction. Will you leak troponins and CKMB? Yes. So those will be positive. Those are the big things to remember. Now that we've done that, I want to quickly talk about these biomarkers, the troponins and CKMB. So again, if we had like a myocardial cell here, the myocardial cell has these very special types of molecules that are present within them called troponin and CKMB. And there's even another one called myoglobin. The pink one we're going to represent is troponin. And there's what's called troponin I and troponin T. If there is tissue destruction, like infarction, these molecules will leak out of the cells. Okay? Troponin I and troponin T. And these blue molecules will leak out of the cells, which is called CKMB. And this is more specific for heart tissue destruction. Okay. What's the big difference to remember is that troponin I and T, which is represented here, they usually will take they'll take about 12 to 24 hours before they can kind of get to their peak point, which is around the same as CKMB. But the difference here is that CKMB normalizes way quicker than troponin. Look at the difference here between CKMB and troponin's normalization. So that is important because CKMB can be used to determine reinfarction. In other words, someone has a STEMI, their troponins are elevated. Maybe a couple days later, they start complaining of new chest pain. Their troponins are still elevated, so you can't tell, are they having another reinfarction? What could you order? A CKMB, because let's say that it will start to elevate again because it would have normalized and the troponins could still be elevated and have not normalized yet. So that's where it would be important to remember that on your exam for CKMB. Okay. The next thing, so we have a good understanding, we need 12 lead EKGs, we need troponins. We have an understanding of why troponins and CKMB are important in determining tissue destruction. We understand the significance of CKMB for reinfarction. We now need to talk a little bit about the 12 lead EKGs, but what we actually need to know and you will be tested on your exam is knowing which vessel would be the one responsible whenever you look at an actual EKG and you find, oh, here's some ST segment changes, specifically ST elevation, which vessel is the suspected vessel? So we have to quickly go over our anatomy. Okay, so the first one here, you have what's called the left anterior descending artery. Okay, so let's say here we have what's called the left anterior descending artery. The left anterior descending artery will give off a branch right here that supplies your septum. Obviously, this is a cut view of the heart. This is the apex. We cut out the atria, which would be up here. This is the left ventricle. This is the right ventricle, and in between is the septum. Okay, imagine here is your left anterior descending artery, and it's going to give off one branch here. One branch is going to supply the anterior compartment of the heart. All right, so all of this is what's called your LAD right here. So this one right here is called your LAD. It gives off two branches. One is it goes here and supplies the septum, and the other one here is it supplies the entire anterior portion of the heart. Okay? There's a branch that'll actually come off. So you have what's called the left coronary artery. It'll give off this left anterior descending artery. And let's do this one in purple. There's another branch that comes off here, and it goes this way. And it kind of supplies like the lateral wall of the heart, okay? And then comes here and even gives a little bit into posterior branch here. What is this one here called? This one here is called your left circumflex artery, okay? So you have your left coronary artery, which gives way to what's called your left anterior descending artery, which supplies the septum and the anterior wall of the heart. Your left coronary artery also gives off the left circumflex, which supplies the lateral wall of the heart and even a little bit in the posterior wall of the heart. The last one that I want you guys to remember here is that your right coronary artery, it comes off here and supplies your right ventricle. So this is your right coronary artery. It'll give off what's called the marginal branch, and that'll supply the right ventricle and parts of the apex of the heart. It'll also supply all the parts of the right ventricle here and move around and supply like the back part of the septum and give way to another vessel here, which we're going to talk about. So what is this vessel here called? This is called the right coronary artery. Right coronary artery gives off branches called the marginal artery, so it supplies the right ventricle, the apex of the heart, the lateral wall of the right ventricle, posterior wall of the right ventricle, and gives off another branch here. What is this last branch that I want you guys to remember? This last branch that is given off by the right coronary artery will supply the posterior wall of the left ventricle and parts of the posterior component of the heart. And this vessel here is called the posterior descending artery. So, if you were asked, okay, I see signs of an anterior MI, anterior septal, anterior apical, anterior lateral, I would think that the LAD is involved, okay? The leads that are most specifically important here are going to be from V1 to V4. These are the big ones here, okay? but it does give off a little bit to the lateral wall, so you might even see some in the V5, V6. We'll take a look at some EKGs, but these are the big ones that I want you to remember. The left circumflex is going to be primarily supplying the lateral wall of the heart. So the leads that I want you guys to remember for this one is 1 and AVL, as well as V5 and V6. But again, remember that the left anterior descending artery does give a little bit of supply here to that lateral portion of the heart. So you may even get a little bit of left anterior descending there as well. The right coronary artery supplies the inferior portion of the heart. So that would be leads 2, 3, and AVF that you would want to remember, as well as, since you can get a right ventricular infarct, you'd want right-sided chest leads. And we'll show you what those look like a little bit later. And the last thing here is the posterior descending artery supplies the posterior wall of the heart. So if someone has a posterior MI, you actually want to look at what's called V7 to V9. I'll explain why this is important. You actually look at V1, V2, and V3, and you look for some specific changes, and then you can put on what's called posterior chest leads. So these are the big things that I want you guys to remember, and we'll take a look at some EKGs to identify an anterior STEMI, a lateral wall STEMI, an inferior STEMI, as well as a posterior STEMI, okay? All right, now that we know that and we know the vessels associated with those STEMIs, the next thing you need to know is what kind of things may come up on the EKG. Well, here's the thing. What you actually would want to know, and they ask you this on your exam, is the step-by-step sequence by which ischemia or infarction progresses on the EKG, because they may come and see you at one particular point in time. And so one of the big things to remember is the first thing that actually kind of generates in a patient who is maybe having some type of ischemia or infarction is it may start off with what's called this is very particular for a MI, hyperacute T waves. This may be the first thing. Then after the hyperacute T waves, they develop ST segment elevation. Then after the ST segment elevation, they develop what's called Q waves. Then after the Q waves, what happens is they get the ST segment normalizes, and then the T wave normalizes. So this may be something that you see in a patient who's having a myocardial infarction, is they may first present with hyperacute T waves, then ST elevation, then Q waves that can stay around for a long time, then their ST normalizes and their T wave will normalize, okay? Sometimes they actually may even get a little bit of T wave inversion in there, sometimes between the Q wave and the ST segment normalizing. So sometimes another thing to remember is that you may get some T wave inversion in between these as well. Other things that you want to look for, though, is ST segment depression and T wave inversion by itself, because that may be indicative of NSTEMI or unstable angina, and that's also important. Okay, so these are things that we will take a look at some EKGs. The big ones that you need to remember is the STEMI stuff, and that's what we'll look at in diagnosing ischemic heart disease, particularly MIs. The next thing, echo can be important for diagnosing ischemic heart disease. The reason why is, imagine here that you developed an infarct right here in this left circumflex territory. So the lateral wall of the left ventricle became ischemic, it then infarcted, and it stopped contracting. If I did an echo, I could take a look at the heart in real time and see if that actual component of the ventricle is contracting as well as the other parts of the ventricle are. And so sometimes this can show me something called wall motion abnormalities. And this is very important that sometimes we can pick up in patients doing an echo bedside. The best test that you can possibly do, the most definitive diagnostic test. So if you had the best test, if there was a question about what is the most definitive test, the most diagnostic test for someone having a myocardial infarction, it would be what's called a cardiac catheterization. We just like a cath. So if you do a left heart cath, that would be the best scenario. What they do is they take a catheter, thread it through, make it the radial artery, the femoral artery, and they take that up and look into the vessels of the heart. They look at the left coronary artery, the right coronary artery, and they shoot some contrast, light it up, and you can see the picture and see the flow of the contrast through the vessels. And if the contrast is maybe going through one area and it stops, there might be an occlusion in that vessel, and you can visualize that. And concurrently, here's the best thing about why this cath is the best. It's diagnostic, but also can be used therapeutically. So in real time, you can also do something that we'll talk about later called a percutaneous coronary intervention. In other words, they shoot the contrast, they see, oh, the left circumflex is occluded, 98%. Guess what? I'm going to thread a balloon in there, I'm going to dilate it, and put a stent in it and keep it open now. That is the benefit to catheterization. So if you're ever asked that question, please don't forget this is the best test because it's diagnostic and concurrently therapeutic if you're getting a PCI. All right, done there. Now, this really, if you think about it, our discussion with the EKG, the vessels, the echo, the cath, that was really kind of taking more specifically a look at STEMI. A little bit on NSTEMI, but primarily STEMI. My question to you is, okay, Zach, there's a lot of things that you're hitting me with right here. How do I know like the step-by-step approach? That's what I want to know. If I get this question on the exam, I need to know. So I got you. If a patient comes in with ischemic chest pain, do you have concerns that it is one of these things? What's the first test that you should do? The first test that you should do, if you are concerned for ischemic heart disease, is you should get a 12 lead EKG or ECG. If you get the 12 lead ECG and it shows ST segment elevation, there used to be a thing that said new left bundle branch block. That's actually kind of been changed recently. So we're going to primarily go with just ST segment elevation. If you get the 12 lead ECG, ST segment elevation is present, where do they go? The best thing that's diagnostic and therapeutic? They get a cath. So they're going to go to the cath lab because then we can see, is there truly an occlusion? And if there is, I can fix it. And they go emergently right away. If you get the 12 lead ECG and it does not show, so no ST segment elevation, but maybe there's ST segment depression, T-wave inversions, or there's just some non-specific stuff on the EKG. What would I get then? I order my tropes. Okay? If I get the 12 lead, no ST elevation, I get the tropes, and my tropes are positive. They're elevated. Do they go to cath? Okay, so this is where we got to talk about something. We can risk stratify these patients because I really need to have a good idea for those patients that are what's called non-ST segment elevation acute coronary syndrome, which could be unstable angina or NSTEMI. How do I know? Because if it's a STEMI, I know they go to the cath. But if it's NSTEMI or unstable angina, do I medically manage them? Do I still send them to cath? How do I know? So here is what's called the TEMI score. And this is something that you may be asked on your exam. The TEMI score risk stratifies these patients of NSTEMI and unstable angina and determines their need for catheterization based upon a risk of mortality. And so what it looks like is a very easy way to remember this is the mnemonic America, okay? A for age greater than or equal to 65. M is for markers, so troponins are elevated. E is for ECG. It shows ST depression, some deviation really. They have risk factors, at least 3 or more for coronary artery disease, diabetes, hypertension, smoking, age, all of those things. They have ischemic chest pain with at least 2 events within a 24-hour period. They have coronary artery disease with actual visualization of 50 or greater percent stenosis of one of their coronary vessels. They have aspirin use within the last 7 days. You take all of these up and you kind of go through their chart and say, okay, let me calculate all of these or off of the clinical vignette. And you calculate their TIMI score. If the TIMI score is 0 to 1, they're very low risk. These patients, medically, manage. Okay? And then reevaluate and determine their need maybe later for other things. If they're greater than or equal to 2, they're high risk and they should be considered for a catheterization, maybe not emergently, but maybe urgently within the next day or 2, we should take them to the cath. Okay? So if their tropes are positive, you do the TEMI, and if the TEMI is greater than or equal to 2, they'll get the cath, but maybe not right away in the next day or 2. It is not emergent, it's now urgent. Okay? All right, you've done this, 12 lead EKG, ST, we've taken care of STEMI. No ST elevation, so now we have unstable angina and STEMI. If that's the case, we get the tropes, we TEMI to risk stratify, determine their need for cath versus if they need to get medically managed. Okay? The next thing is, what if the tropes are negative? That could be, what, Prinzmetal's angina, or it could be ST, oh sorry, couldn't say that, my bad. Okay, all right.
Okay, so it's negative.
Okay. All right, so the tropes are negative. What could it be then? Well, that kind of really just leaves us with that stable angina picture, because again, we're talking about ischemic heart disease. Prinzmetal's angina, again, it may present with ST elevation. Look at their risk factors. Look at what we talked about over there in the beginning part of the board. So let's just think about what this would be left with. If there's no ST elevation, the tropes are negative, that leaves one last one, stable angina. So this would maybe kind of put us in the category as, is this stable angina? If it is stable angina, the next thing that we have to do is we have to determine, okay, do they need to go to cath? Well, how do I determine their need to potentially go to cath, or if I can medically manage them? The next thing we do is we determine, should they get a stress test? And if the stress test is positive, and I'll explain what the heck that means, then maybe they eventually should go to cath within some time soon. It doesn't have to be within a day or 2. It can be electively whenever they need to. So the whole process here is that ST elevation, they go to cath emergently. No ST elevation, tropes positive, TEMI greater than or equal to 2, they go to cath urgently. Tropes negative, potential is questionable, stable angina, you get a stress test, it's positive, they can go electively to get a cath. Okay? How do you determine a patient's need for a stress test? I'm so glad you asked. So the way that we determine a patient's need for a stress test is if they have we will look for a very, very particular thing. For stable angina, we wanted to get a stress test. We look for what's called an intermediate probability of them having stable angina. And so we look at what's called the Diamond classification, ask, is this anginal chest pain? And we look at their age and their gender, and that helps to determine their probability, their risk. If they have substernal chest pain, okay, their pain is worse with exertion and relieved by nitroglycerin. That's very characteristic of stable angina. And depending upon their age, if they're a little bit older, again, male, female, depending upon that, we can say, all right, they're an intermediate probability of stable angina, ischemic heart disease. Let's go ahead and get a stress test. So that is what we kind of look at here. Now, once we've done that and we said, okay, we should do a stress test for this patient, let's now talk about the stress test. Stress testing is important. This is going to come up on the exam. It is only important for flow limiting stenosis. It is not going to diagnose an MI. It will miss MIs potentially. So it's only good for flow limiting stenosis, which is important in something like stable angina. So how do we do that? How do we determine these patients? Again, this is also very important. They have to be within that intermediate probability. If they have a low probability of coronary artery disease, you do not send them for this test. And if they have a high probability of coronary artery disease, you don't send them for this test. You maybe do a catheterization a little bit earlier than before doing a stress testing. Okay? So when we do a stress test, it's basically what we talked about. With patients who have a decreased oxygen supply because they have an occlusion, if they have an increased demand, it will worsen the ischemia, worsen their chest pain, and potentially bring about some diagnostic cues. So what we do is we have the patient work out, ideally, have them walk on a treadmill, and increase their oxygen demand to produce an ischemic event. How do we do that? Well, first we have to find what is their max heart rate, and we determine that by taking 220 minus their age. Then we take 85% times that max heart rate, and that's the target heart rate that I want them to work out to. And once they reach that, I've reached the point where I've demanded their myocardium to have a high oxygen demand, potentially provoking ischemia. When I do that, first thing I'll do is I'll get an EKG at rest, at baseline. Get a baseline EKG, a baseline echo, okay, or a baseline myocardial perfusion imaging. It's a nuke med scan. You give them something called technetium. It's a radioisotope, and it can kind of bind on to different myocardial cell areas that particularly are kind of like well perfused. Okay, so that's important to remember. Okay, so what we'll do is we'll get a baseline EKG, echo, or myocardial perfusion imaging. Then if we can, we'll have them work out, reach their target heart rate. If they start having anything on their EKG afterwards, after we've had them reach their max heart rate, they start developing chest pain, their blood pressure starts changing, we get an EKG and it shows ST segment depressions or T wave inversions. This is a positive test for the 12-lead EKG stress test, okay? If their EKG is uninterpretable because maybe they have like a pacer, maybe they have a left bundle branch that's kind of like skewing their finding any ST depressions. Maybe they have other kinds of abnormalities in their EKG. They have previous like Q waves or things like that it's hard to be able to kind of discern if this is new or old. Then that can kind of make things challenging, and you can avoid doing a stress EKG test and going straight to what's called a stress echo. Again, get the baseline echo, take a look at all the heart motion, then have them work out, see if any area becomes ischemic with that working out on the treadmill. And what you look for is afterward, do they have what's called any wall motion abnormalities? If they have any wall motion abnormalities, this is a positive stress echo, okay? The next thing we can do is we give them the radioisotope technetium. It binds onto different well-perfused areas in the heart and leaves areas kind of like what's called a cold spot in areas that are not well perfused. And so we'll get a good image of what their heart looks like at rest. Then we'll have them work out. After we have them work out, we give them another radioisotope of technetium to see if it binds to any areas that are ischemic. If you see any what's called cold spots or areas of poor perfusion of the actual myocardium after they've been exercising, that is a positive test. Okay? Here's the last thing that you guys will need to remember. And patients that cannot exercise, maybe they aren't able to exercise because they don't want to, they have some type of disability, they're wheelchair bound, whatever it may be, and they just aren't able to do the exercise component of it, you can replicate that by utilizing particular medications. And this is called pharmacological stress testing. And they love to ask this on the actual USMLE Step 2. So when we talk about that, it's important to remember the pharm stress test. We can kind of replicate working out in an interesting way. So what we do is we can give a couple different medications. I only want you to remember just a few. One is if we do the echo, we can use a drug called dobutamine. Okay? This would be particularly for the echo. So it would be a pharmacological stress echo. The other ones that we could use is what's called adenosine or what's called dipyridamole. And these are vasodilators, and these are best utilized for the MPI, the myocardial perfusion imaging. Okay? So, when we do these pharmacological stress tests, again, we can do with dobutamine. It's best done with the echo. Or we can do with adenosine and dipyridamole. That's best done with the myocardial perfusion imaging testing. All right, so how does this work? Well, dobutamine, all right, this is interesting. It's pretty cool. Dobutamine likes to bind on to beta-1 receptors on the myocardium. And then you also know that we have our nodal system, like we have what's called our SA node, our AV node, and then we have our bundle system. They also have beta 1 receptors on them. So if you give someone dobutamine, it's going to stimulate their beta 1 receptors on their heart, like the actual nodal cells, and their myocardium. If that's the case and you stimulate those beta 1 receptors, that increases heart rate and that increases their stroke volume. That will actually cause their contractility to increase. If you increase their heart rate and you increase their stroke volume, that increases their oxygen demand because now their heart is working harder. It's replicating them exercising. So you would have them get an echo when they're at rest, give them dobutamine. After you give them the dobutamine, do another echo and see, did the dobutamine stress them enough that it caused their myocardium to work so hard that it needed a higher oxygen demand and the supply wasn't enough that it starts to show a wall motion abnormality. That's a positive echo, positive stress echo. The adenosine and the dipyridamole, this one is honestly, it's so dang cool. Imagine here, we have a vessel that's supplying, since we've been using this color here, imagine this is the vessel that's supplying the myocardium, but we kind of zoom in on it. Imagine here it is and it kind of bifurcates here, and it bifurcates here. Imagine here's your occlusion right here, okay? There's a tiny bit of blood that can actually trickle in, right? This shouldn't be a complete occlusion, right? It should be only about like greater than or equal to 70%. So there should still be blood that's getting by. In this diseased vessel, it's already pretty much maximally dilated. You give adenosine and dipyridamole. What this does is adenosine and dipyridamole bind onto the healthy vessels and cause these bad boys to dilate maximally. When these dilate maximally, that is going to open them up to allow for blood to easily flow right into them. Adenosine and dipyridamole don't really work well on diseased vessels, so it doesn't really produce a dilation effect here. Where are things going to want to go? They're going to want to go in the path of least resistance. So when blood is flowing and it has to run down these areas, it's going to want to move into the well-dilated and well-opened, low-pressure areas. And so blood will get stolen away from this coronary vessel and diverted into these areas. The problem with that is that the blood that's going to this part of the myocardium will be starved of oxygen and it'll start to become ischemic because you're stealing blood away from it with these vasodilators. This is a very specific name that you have to be ready to see on the actual exam. It's called coronary steal syndrome. So what you would do is you would have the person, you give the radioisotope of technetium, take a look at their heart, look to see if you see any cold spots or poorly perfused areas. Once you've done that, you give them the adenosine or the dipyridamole. After they've done that, it should induce this coronary steal syndrome, cause areas where this kind of like occlusion is present. The myocardium should become ischemic. When you do the MPI, again, you should see very poor areas of perfusion that's actually supplied by that vessel. And that would be a positive stress test, particularly via this MPI testing. And engineers, I hope this part of the diagnosis made sense. Let's take a look at some images of EKGs to really nail some of this stuff down, and then let's finish up with the treatment of ischemic heart disease. All right, engineers, so let's go ahead and take a look here at an EKG because this is very important. We have to be able to identify STEMIs, ST segment elevation, myocardial infarctions for your step 2 exams, as well as in patients who come and you see this clinically out there on in the wards. So we have this EKG here. This is our 12-lead EKG, right? You always have to go through every EKG the same way, right? Rate, rhythm. You can then determine the axis. You can even then move on to your ST segments. For right now, we don't have a rhythm strip, so we're going to kind of skip the whole rate rhythm process, and we're going to look for any ST segment deviation. Is there any ST segment depression, any ST segment elevation? And so you're going to want to move through this in kind of the same step-by-step process. I'm going to go all through my limb leads, and then I'll go over here into my precordial leads. So if I look at lead 1,
I can look at my ST segment here. It does look a little bit elevated. It may be subtle. It may be very subtle here in lead 1. If I look at lead 2, my ST segment looks good. Lead 3, nothing really, specific here. There may be some type of like ST T wave kind of abnormality there. If I look at AVR, again, nothing really special there. But if I look at AVL, ST segment definitely seems a little elevated, kind of subtle, but it definitely looks like there's some elevation of the ST segment in AVL. So 1 and AVL look a little bit elevated. If I look at AVF, it looks the same. If I come over here to V1, that ST segment definitely looks elevated though. Here in V1, I can kind of mark that over here. V2, that ST segment looks elevated, and these T waves even look a little funky. So these T waves are pretty big, and they're asymmetric. And so this is actually called a hyperacute T wave, and this is kind of an early sign of potentially ischemia progressing to infarction. So hyperacute T wave, ST segment elevation, and you know what else is interesting here? It's definitely relevant here. You know how whenever you have someone with you have your QRS complex, if you look here, you have a Q wave, and it's a very significantly deep Q wave, and it's also wide. So I have what's called a pathological Q wave here. Pathological Q wave here, but here I actually do have, this upgoing portion here. So I definitely see a Q wave here in V1 and V2. ST segment elevation with hyperacute T wave so far in V2. I see ST elevation in V3 with a hyperacute T wave. I see ST elevation in V4 with a hyperacute T wave. And V5, it's very subtle. I would say that it's pretty much no significant ST elevation in V5, and I would say no ST elevation in V6. So to summate what I see here, I definitely see some elevation in 1 in AVL. It's subtle, but it's there. But the main ones that I definitely see here is ST elevation a little bit in V1, definitely in V2, definitely in V3, definitely in V4. I definitely see some hyperacute T waves in V2, V3, and V4. So right away, something should be kind of pointing out here, especially these precordial leads. So V1, V2, V3, V4, what vessel supplies this area? That's the left anterior descending artery. So if there is an occlusion of the left anterior descending artery, that can produce ischemic changes or infarction changes on V1, V2, V3, V4. And if it does start affecting some of the lateral part of the anterior side of the heart, anterior lateral, you may see some mild changes in V5, V6, 1 in AVL. So I have a suspicion that this person has an anterior MI. Let's take a look at the significant points here. So if we look at this here, I definitely can see ST elevation here in AVL. I definitely see it in 1. I see it not as significant in V1, but I definitely see it in V2. We have the hyperacute T wave, see it in V3, hyperacute T wave, see it in V4, hyperacute T wave. So most significantly is elevation in V2, V3, V4 with hyperacute T waves, 1 and AVL. Now, something else that you want to make sure that you check for is what's called reciprocal changes. So any evidence of ST depression or a T wave inversion. And if I look here, that's reciprocal changes are very significant for STEMIs in comparison to other things like benign early repolarization. So if you look here, I definitely have my ST segment is depressed. It's below my TP segment. So if I look here, it's definitely at least a millimeter below my TP segment. So reciprocal changes here in 3. And so I would definitely say that this is an anterior and even starting to extend into the lateral, because remember the lateral is the 1 in AVL. So definitely a significant LAD occlusion that's causing ischemia to the anterior septal and anterior apical and even parts of the anterior lateral portion of the heart with reciprocal changes and lead 3. So this is our anterior STEMI. All right, engineers, let's take a look at this next EKG here. So again, go through, determine your rate, your rhythm, And if we were to go through this, it looks like it's going at a, a decent rate, not too fast, not too slow. Rhythm, it looks regular, so I don't see any irregular rhythms. And then again, you always want to determine, is it sinus or is there any other type of arrhythmia? And here I have an upright P wave in lead 2, and I have an inverted P wave in AVR, and it's following that normal PQRST pattern. So this is a normal sinus rhythm, but again, we want to look at our ST segments here. So if I go through one all the way, through my limb leads and into my precordial, holy dookie, there is a big ST segment elevation here in lead 1. Definitely pretty big here in lead 1. If I look at lead 2, nothing really significant there. Look at lead 3. Oh, there's definitely some ST segment depression. Obvious there in lead 3. That could be a reciprocal change, right? In order to have STEMIs, you definitely want to find reciprocal changes. AVR, nothing really popping out obvious right now. And again, AVR is it's one of the interesting ones. You can find like a very main stem kind of occlusion, so it's something to look for. But AVL is the next one. Ooh, elevation in AVL. So if I have ST segment elevation in lead 1 and ST segment elevation in AVL, those are two leads that are involved with the lateral wall of the heart, the anterior lateral component. And the distal portion of the LAD supplies that one, but the big one is the left circumflex artery. So could there be an occlusion of the distal LAD or the left circumflex artery that's occluding the blood flow to the lateral portion of the heart, the left side particularly? Well, let's keep going. We go to AVF, ST depression. That could be a reciprocal change. Go to your V1. There's a little bit of ST depression here in V1, ST depression in V2, ST depression in V3. Looks normal in V4, but V5, I appreciate some ST segment elevation in V5 because there's, again, we have coming down here, S wave and up to right up to that portion there is our, this is going to be where we start that J point. So that's definitely around the ST segment there. So that looks elevated. V6, it's like very subtle. There may be some mild elevation of V6 there. So what I would definitely assume here is that 1, AVL has ST elevation, V5 has ST elevation, and there may be some subtle elevation in V6. Reciprocal changes that I'm appreciating is in V1, V2, V3, 3, and AVF. So what can I assume that I see here? I see ST elevation in lead 1. I see ST elevation in AVL. That's definitely hitting like the high lateral portion of the left ventricle. If I go over to V5, definitely some obvious ST elevation here in V5 that's hitting that anterior lateral portion of the left ventricle. And V6, again, it has to be about 1 millimeter, and it's probably maybe just exactly 1 millimeter above. Very subtle ST elevation of V6. So definitely the high lateral portions of that left ventricle is getting hit. And then you're getting some of like the anterior lateral portion definitely with V5, a little bit less of V6. And then again, we're getting reciprocal changes in V2, V3, 3, AVF, and a tiny bit in lead 2. All right, that covers the lateral ST segment elevation in my. All right, engineers, let's take a look here at this EKG. So again, we're going to go through, determine our rate, our rhythm, determine if it's sinus, so again, and we can look here, rate looks good, not too fast, not too slow. Again, rhythm looks regular. The R-to-R intervals are around the same kind of interval. And then again, look at lead 2. Is it upright in lead 2? It is. And then the P wave is inverted in AVR. So this appears to be sinus rhythm because the P always follows with a QRS and then T wave. So normal sinus rhythm. But again, we want to know about those ST segments. So look at 1. What do I appreciate in 1? I appreciate ST depression. So definitely some ST depression in lead 1. Lead 2, I see ST elevation. Okay. Lead 3, I see ST elevation. AVR, again, not too worried about that one right now. AVL, I see ST depression. Okay. And then AVF, I see ST elevation. Well, that's interesting because I know that 2, 3 AVF, if they're elevated, that's the inferior wall of the heart. Okay, so I got to be thinking about an inferior STEMI, and then these could be reciprocal changes in lead 1 and in lead AVL. So I would definitely assume that this is an inferior STEMI with elevation in lead 2, 3, and AVF, and reciprocal changes in 1 and AVL. But let's be consistent. Let's go through everything else. If I look at V1, I don't really appreciate anything super significant here. There might be some like very subtle elevation here in V1. Nothing special in V2, V3, V4, V5, or V6. So I'm definitely seeing some obvious ST elevation in 2, 3, AVF, reciprocal changes, and 1 in AVL. So this would make me think of an inferior STEMI. Okay, and an inferior STEMI is very classic to think about whenever you have 2, 3, and AVF being elevated, with reciprocal changes and 1 in AVL. So now, inferior STEMIs are usually associated with an occlusion of the right coronary artery. There's a concern when it comes to that, because if you have an occlusion of the right coronary artery, not only do you affect blood flow to the inferior, especially if it's a proximal right coronary artery, not only do you affect blood flow to the inferior wall of the heart, but you also can affect blood flow to the right ventricle. And so they can develop right ventricular infarctions. So we have to be thinking about that. And so if we have a patient with an inferior STEMI, we should evaluate right-sided chest leads to see if there is any right ventricular infarction. All right, engineers, let's take a look here at this EKG. So if we go through, again, we want to determine if it's, the rate, the rhythm, and we don't have a lead, we don't have a rhythm strip here on this one. But again, for this one, we want to look at those ST segments. So if we take a look here, let's go from 1 all the way through. Here on lead 1, I see ST segment depression. In lead 2, I see ST segment elevation. In lead 3, I see ST segment elevation. If I look at AVL, I see ST segment depression. And in AVF, I see ST segment elevation. Okay, very interesting. If I go over to V1, nothing really special. V2, there might be a little bit of ST depression here. And again, I don't see anything in V3. Well, let's come back over to this one here in a second. This is interesting. I'm getting a little ahead of myself. But if you remember what we talked about with inferior STEMIs, we definitely have an inferior STEMI here. We just covered this, right? There's elevation in lead 2 and 3 in AVF. So that's definitely inferior STEMI with reciprocal changes supporting that in 1 in AVL. Remember, if you have an inferior STEMI, you should have potential concern and have a high degree of suspicion for a right ventricular infarction. And so what we have to do is we have to get the chest leads, especially the precordial leads like V1 through V6. We want to have them track over into the right side towards the right ventricle. So we put chest leads on the right side. And so what we'll do is we'll actually check the chest leads on the right side. We'll go like V1, V2, V3R, V4R, okay? And so if we do that, we're going to go ahead and throw on the right-sided chest leads, and they put in the kind of R here to indicate that these are now right-sided chest leads. What do I see? I see ST segment elevation and V4. If there's any elevation generally within your right-sided chest leads, within these precordial components, you should be concerned for a right ventricular myocardial infarction. So if someone has an inferior STEMI via 2-3 AVF with 1 AVL reciprocal changes, you throw on the right-sided chest leads, and if there's any ST elevation within at least like V1 to V4R, you should be on high suspicion of them having an associated right ventricular myocardial infarction. And this patient does. So if we take a look at the overall summation of this kind of EKG, we have ST elevation in 2, 3, and in AVF, reciprocal changes in 1 in AVL. This is an inferior STEMI. Get your right-sided chest leads on, so V1 to 2, 3, 4. And then again, look for any ST elevation within these, and we have ST elevation in V4R, indicating that this is a right ventricular myocardial infarction in association with an inferior myocardial infarction. All right, engineers, let's take a look at this last EKG here. So this one's a very interesting one. So we have a patient here. We're going to take a look at their EKG. We would go through the normal way, rate, rhythm, determine if it's normal sinus. Obviously, we want to find an arrhythmia first. For this one, we're going to go straight to the ST segments. Look at 1, no elevation, no depression. Look at 2. Oh, that's interesting. I appreciate maybe a little bit of subtle elevation here. Maybe about 1 millimeter at least. 3, it's tough to say for 3. I'd say maybe potential some subtle ST elevation, but nothing that I can obviously pinpoint really clearly in this one. We'll go to AVL. No changes in the ST segment in AVL. AVF, I'd actually appreciate some subtle ST elevation, maybe about 1 millimeter. Okay, so some inferior involvement of the heart. There's no ST depression or reciprocal changes here in 1 and AVL, so I don't know. There may be some inferior wall involvement, and we got to think about that. What blood vessel supplies the inferior wall? The right coronary artery. The right coronary artery supplies the inferior part of the heart, the right ventricle, and it even goes back and gives off the posterior descending artery, and that supplies the posterior and posterior inferior portion of the heart. So that begs the question, is there any inferior involvement of the heart, but it could be posterior related? Because again, the PDA is supplied by the right coronary. There could be. It could be. Well, we got to keep an eye. So let's keep going. So we look here at V1. I appreciate some T-wave inversion. V2, ST depression. V3, obvious ST depression. And V4, there's actually some ST depression as well. V5, I don't appreciate any ST elevation or depression. V6, I appreciate ST elevation, though. That's wonky and interesting, but it's there. So one of the definite things I can say here is the most obvious and definitive is T-wave inversion in V1, ST depression in V2, V3, V4, and some subtle ST elevation in 2 and AVF. So here's the thing that we got to think about here, which helps us to really think here thoroughly. If we have inferior elevation of the ST segment in 2 and AVF, even though it's subtle, and we have ST depression, T-wave inversion in V1, V2, V3, and V4. Remember, the posterior descending artery gives way to the posterior and inferior portion of the heart. That doesn't pick up ST elevation on your precordial V1 to V6 chest leads. You would have to put the chest leads on the posterior part of the chest wall to pick up ST elevation. Is this T-wave inversion and ST depressions in V1 all the way to V4 actually ST segment elevations if we put posterior chest leads on? Because if it is, that would explain this being a posterior and inferior ST segment elevation MI. Well, the only thing that we can do is put some posterior chest leads on. But before we do that, let's summate what we see here. Big things: T-wave inversion, ST depression in V2, V3, and actually there should be another one here in V4. And then some subtle elevation in 2 and AVF and this wonky V6 finding. So what we're going to do is we're going to put on some posterior chest leads. If I put on these posterior chest leads, again, I'm just basically replacing this. This is V7, this is V8, this is V9. So these are basically the posterior chest leads here. When I look there, I still see something. I don't really appreciate significant ST elevation again in 2, and I don't really appreciate significant in AVF here with the posterior leads. But oh my goodness. In V7, I definitely see some ST elevation. V8, I appreciate ST elevation. V9, I appreciate ST elevation. So with that being said, I think that this is a posterior and maybe even an inferior STEMI. And so what can we say about this one? I see ST elevation in V7, V8, and V9. That was where there was ST depression and T-wave inversion. Obviously in V7, what was previously V1, V2, V3, I see this now elevation in 7, 8, and 9. I don't really see that in V4 over here though. So I definitely think this is a posterior STEMI with even maybe some inferior wall involvement. So that is something to think about, and I think that would be this diagnosis of this EKG. All right, engineers, I hope that made sense. Let's get back to the whiteboard. All right, engineers, let's finish this up with talking about the treatment of ischemic heart disease. Okay, the way I like to help to remember this stuff in my head of how to remember the treatments, there's different mnemonics, and those are great, but I think it's also important to understand the pathophysiology, right? So if we think about the issue with these problems, the big issue is that you get those plaque formations, right? And if those plaques rupture, it increases the risk of forming a thrombus on that plaque. So our goal should be not only to reduce the plaque formation, but to reduce the risk of thrombosis on those plaques if they rupture, ulcerate, fissure. So what drugs can we give to prevent that actual thrombosis from occurring? We can give antiplatelet agents because that's the problem. Remember what I told you, that if you have here this plaque, right?
This plaque is forming, and then again, you get that rupturing, that ulceration, the fissuring of the plaque, exposes that thrombogenic core of fat tissue. Platelets just love to stick to that area. Now here's the problem. If we zoom in on one of these bad boy platelets, these platelets have a bunch of granules that they release, like ADP, thromboxane A2, 5-hydroxytryptamine. There's so many different molecules that they release. The whole significance of these molecules is that they tell nearby platelets, hey, come over to where we're actually forming this clot, buddy, and help to stick and keep forming more of a platelet plug around this so we can just block up this dang vessel. So it stimulates what's called platelet aggregation. The other thing that it does is, not only does it stimulate the platelets to come to that area to stick to one another, it actually enhances their stickiness. So you know, on these platelets they have different types of proteins, like GP proteins, glycoproteins, like GP2B3A, and all these different types of molecules. What these molecules do is they actually stimulate the expression of these proteins and the stickiness of these actual proteins. So that when the platelets come together, not only do they aggregate to the area, but they stick to one another. We should give drugs that block this type of signaling pathway and block the stickiness of these proteins. And that's where these drugs come in. So we can reduce this risk of thrombosis. The first one, aspirin. Aspirin works by inhibiting thromboxane A2 formation. You know, aspirin inhibits the cyclooxygenase enzyme, which helps to break down arachidonic acid into different types of prostaglandins. One of those prostaglandins is actually thromboxane A2. What does thromboxane A2 do? Stimulates platelet aggregation. If we give aspirin, it'll inhibit this thromboxane A2. It'll stimulate the platelets from wanting to come in, stick to each other, and aggregate to the area of where this actual thrombus is forming. That's a beautiful thing. The next one is we have other antiplatelets, just a lot stronger than aspirin. Somewhat stronger than aspirin. And these are called P2Y12 receptor inhibitors. Like, what the heck that mean? You know ADP, adenosine diphosphate? There's little receptors where it loves to bind. And these receptors, you guessed it, are called P2Y12 receptors. What if we give a drug, clopidogrel, also known as Plavix, ticagrelor, also known as Brilinta, or prasugrel? We give those drugs and they bind on and block ADP. We give these drugs, they bind onto this P2Y12 receptor and block ADP from working. What does that do? That reduces the platelet aggregation and reduces the stickiness of this platelets. That reduces the risk of thrombosis. So again, what do these particular drugs do? They inhibit ADP receptor binding. Okay? So these are the two big ones, okay? The next thing is, what about this guy, heparin? Heparin is actually beneficial, especially in patients with STEMI, NSTEMI, unstable angina patients, but it's really very significant for those patients who are eventually going to get a cardiac catheterization. If you're not getting a cardiac catheterization, there's no superior benefit to heparin. How does heparin work? You know, heparin is it's kind of an interesting molecule. We actually make it kind of endogenously. Here's this kind of purple protein here, and this is your heparin molecule. What heparin does is it binds onto a molecule here called antithrombin 3. So this molecule is called antithrombin 3. So antithrombin 3. And what antithrombin 3 does is it inhibits what's called thrombin. Go figure, right? And factor 10. And these are basically, what's the significance of thrombin and factor 10? The whole significance of these molecules is that they help to be able to form that fibrin mesh, yeah? They help to induce that coagulation response. And if you induce that coagulation response, you're eventually going to lead to those fibrin strands, which helps to kind of anchor down a clot. If we give heparin, will actually enhance the activity of antithrombin 3. If we enhance the activity of antithrombin 3, we decrease the activity of thrombin and we decrease the activity of factor 10. If we decrease the activity of factor 10, we decrease this coagulation and fibrin mesh. We decrease clot formation or we decrease thrombosis. So these are also medications to give. So again, it works by increasing antithrombin 3 molecules. And it depends. There's 2 different types of heparin. I don't want to get down the rabbit hole. There's unfractionated heparin and low molecular weight heparin, and they can work by different mechanisms. I don't want to go down the rabbit hole here. But low molecular weight heparin seems to be superior, but we can give unfractionated heparin as a drip. And you can get pretty tight control of that. Either way, remember this mechanism, and remember it's best if you're getting the cath. If you're getting the cath, heparin's beneficial. If you're not, they don't usually use it. Okay, the next thing that you guys need to think about is statins. Now, statins don't necessarily reduce thrombosis. They more likely reduce plaque formation and by virtue potentially reduce thrombosis. So you know statins, they're HMG-CoA reductase inhibitors. There's different types of statins, but basically the whole goal is to be able to reduce the amount of what? The goal is to reduce the amount of LDL and hopefully increase the amount of HDL. And theoretically, by doing this, this should decrease plaque formation. And by virtue, if you decrease plaque formation, you may decrease the risk of forming future thromboses on top of them. But they don't directly reduce thrombosis. That's the important thing. Okay? So aspirin, P2Y12 receptor inhibitors, especially clopidogrel is a big one. Heparin if they're getting the cath, statin to reduce the plaque formation. Doesn't directly stop thrombosis. Okay, other things that you obviously consider is modifiable risk factors: diabetes, good glucose control, exercise, diet, blood pressure, okay, hypertensive, take your blood pressure medications, okay, lose weight, exercise, less salt intake, obesity, lose weight, exercise, diet. Again, if there's alcohol, reduce your alcohol consumption. Smoking, smoking cessation. So there's a lot of things that we can modify, change, and that may help reduce the risk of atherosclerotic plaques, right? One of the things that's big here that actually is recommended in the long-term treatment of patients, as long as their blood pressure can tolerate it, is ACE inhibitors. ACE inhibitors have been, they're good for, again, blood pressure. They can obviously lower your blood pressure. But one of the good things is that they've been shown to reduce cardiac remodeling, especially in patients who have had myocardial infarctions. So if the blood pressure can tolerate it, we prefer to give ACE inhibitors, captopril, enalapril, lisinopril, long term, okay? So these are some medications that we have here that I want you guys to remember, okay? But again, also don't forget about those other modifiable risk factors: diabetes, obesity, smoking cessation, so on and so forth, reducing alcohol consumption. All right, now that we got these down, let's now talk about the next thing that you have to focus on. So we talked about potentially reducing thrombosis. Second thing is, okay, what if I can't really, that's not the only thing I can do. Can I do anything about this demand of oxygen? Can I reduce the oxygen demand? And so that way, whatever supply I'm getting, it's fixed at this point in time. If I reduce my demand, I can still potentially reduce the level of ischemia and hopefully progression to infarction. Reduce the progression to infarction. How do I do that? You can give a couple of drugs. The first one here is nitroglycerin. Now, nitroglycerin is a pretty interesting drug. And what nitroglycerin is it's kind of like it's a vasodilator, but particularly like venous system and coronary arteries that also can dilate. So here's what I want you to remember for nitroglycerin. Nitroglycerin will kind of cause venodilation. Now imagine venodilating like the vessels that drain into the inferior vena cava. If you venodilate, you open up the diameter. If you increase the diameter, what does that do to the resistance?
that decreases the resistance. And if you decrease the resistance, what does that do to your pressure? That's a lower pressure then. And we already know that blood flow through the venous system is low, but if you venodilate, it's going to be even lower. That means if I venodilate, I'm going to get less venous return to the heart. Less venous return means less preload. Less preload means that the ventricles don't have as much volume. So in other words, if there's less preload, there's a less stroke volume. Less stroke volume means that the ventricles don't have to work as hard to pump a bunch of blood out. That reduces their oxygen demand. So nitroglycerin works by, one way, decreasing preload, which reduces stroke volume. If you reduce stroke volume, you reduce the actual oxygen demand. You reduce the degree of contraction that the ventricle has to go through to pump blood out of the heart. Okay? The other thing it can do is that nitroglycerin can also cause vasodilation of the coronary vessels. If you open these vessels up, especially near areas where there's some stenosis, it may open up the vessels enough to perfuse the actual ischemic cardiac tissue. And so the other thing that it can do is it's a coronary vasodilator. Okay, here's the thing that you need to remember, which may come up on your exams. Nitroglycerin you do not give to patients who are preload dependent. Do you remember I talked about that not too long ago with clinical features and complications? A right ventricular MI, they're preload dependent. Their right ventricle isn't really working very well now. They're very preload dependent. They need a good preload. And so in these patients, we don't want to take away their preload even more. And so for these patients, nitroglycerin, it is contraindicated. Do not give in right ventricular MI. Okay, it is contraindicated. Do not give that. Also, you shouldn't give it in patients who are taking phosphodiesterase inhibitors because those also can dilate vessels and potentially worsen the preload. And sometimes even in patients with aortic stenosis, we also say no. All right, that's nitroglycerin. The next one is morphine. Morphine is also a vasodilator. So it can work by potentially vasodilating some of the veins as well. And if it does that, it can also reduce preload. And if it reduces preload, it may also reduce stroke volume. But it also has the ability to dilate some of the arteries as well. If it dilates arteries, that reduces the resistance as well, and that can reduce the pressure that the left ventricle has to exert to push blood out of the heart. What's that called? Afterload. And so morphine may also reduce afterload. And that may also do what? If you reduce the afterload, you reduce the stress upon the heart, the amount of work that the actual heart has to do. And so that's important there. So we'll just remember that it decreases the afterload. And that reduces the oxygen demand. Okay, what else? All right, the next one that I want you guys to remember, and real quick before we move on to that, morphine is more for like refractory. So you don't want to have to give this. There's literature that suggests whenever you have to give morphine, it's potentially a worse prognosis for the patient, but you can still give morphine if patients are in pain, treat the pain. But nitroglycerin should be first, and if they're still refractory, then you give morphine, okay? All right, the next one is beta blockers. Beta blockers is actually a really good one. Definitely want to remember this one. Very, very important one. So beta blockers are pretty cool. So you know you have beta receptors that are present on two different areas. They're present, like you have your SA node, your AV node, your bundle system, right? So you have beta 1 receptors that are located there, and you have these beta 1 receptors that are present here on the myocardium, the contractile component. If I give a beta blocker, it'll block the contractility. So that's one thing. Already it's going to reduce contractility. If I'm having a reduction in contractility, I don't need as much ATP, I don't need as much oxygen. If I inhibit my AV node and SA node, I decrease heart rate. If I decrease heart rate, I don't need as much ATP to power those electrical pumps, I don't need as much oxygen now. That right there itself can reduce oxygen demand.
Okay? You can also use another drug called calcium channel blockers. Those are generally, you want to be careful if a patient develops decompensated heart failure, you should not give calcium channel blockers. But another drug that you can potentially add on here, we'll do it as a plus or minus one. A plus or minus is calcium channel blockers, particularly the non-dihydropyridine types like nifedipine and lodipine, nicardipine. Those may also work by vasodilating and the arteries, and if they vasodilate arteries, they reduce afterload, but they also may induce some coronary artery vasodilation. And if you give calcium channel blockers, some of them also can block the calcium channels that are present here on the heart and maybe reduce heart rate as well. So those are other things. But again, we don't commonly go to that one first. It's just something else to consider. You may see that. All right, so these are all the things that can reduce oxygen demand: nitroglycerin, morphine, beta blockers, and plus or minus calcium channel blockers. Is there any way we can increase the oxygen supply? Well, that's not really a great thing. You know, like, we don't have much. We have to figure out a way to open up that vessel, really. But if a patient is hypoxic, they have low levels of oxygen within their actual blood, give them oxygen, a nasal cannula, a non-rebreather, whatever it may be. Give oxygen if they're hypoxic. It may help, okay? So that is a big thing to consider. If they're hypoxic, give them oxygen. It may help to increase the amount of oxygen that you can deliver to the myocardium. That's the only time you can really help with the oxygen supply. Okay, we covered these things. The last component to treatment is, we covered the decreased thrombosis, we covered the decrease in oxygen demand, not really much with the oxygen supply, but how can we just open up the vessel, revascularize that entire vessel so that we can perfuse the myocardium? All right, so we talked about how can we reduce thrombosis, how can we potentially reduce oxygen demand and somewhat increase oxygen supply. Obviously, the best thing that you can do for your patient is to recanalize those vessels, open them up, especially if a patient is having severe chest pain, they're having a STEMI, they're having an NSTEMI and unstable angina that's refractory to medical therapy. They're starting to develop complications like heart failure, left ventricular dysfunction. These are all things that maybe are an indication, hey, we need to recanalize this vessel. So what are the ways that we can revascularize or reopen up that vessel? Okay, there's three particular ways that you guys want to remember, but really only two of them are the ways that we can be effective. All right, one is, imagine here is the vessel. Okay, here's this vessel, and here's that occlusion. One way is I can do what's called angioplasty. So remember when we do what's called catheterization, cardiac catheterization, I can thread a catheter through the femoral artery or through the radial artery up into the arteries of the heart. When I go, I shoot some contrast, find the one that's occluded, and put the catheter in that area where it's occluded and blow a balloon up to push that plaque down. Okay? Once I balloon that up to kind of push down on that plaque and make it as small as possible, then what you do is you thread a stent over that. And the stent is going to keep that area nice and compressed and help open up that vessel to keep it more patent. So now if we had comparison, if we had this thing that was pretty much occluding like 80–90% of the vessel, we put the balloon in, push it open, and then put the stent in, we might be able to recanalize it to maybe it's like 10%. It's completely open, right? There's only like a 10% occlusion, or maybe there's 0% occlusion. You get complete reperfusion. This is the next step, as you add in that stent. Okay? This whole process here is called a percutaneous coronary intervention. Okay, that's where we do the cardiac cath, find it diagnostically, treat it therapeutically. This is the preferred treatment for patients with STEMIs. NSTEMIs, unstable angina, they're refractory to therapy. Patients with stable angina that have greater than 70% stenosis of their vessels, and they also have positive stress tests and they elect to go get a PCI. These are the things to remember. The next thing that we can do to revascularize, this is a little bit more intense and you don't want to have to do this one. You'd rather go with the PCI first. But the next thing is, let's say that this vessel is just, it's super occluded and it's like a main vessel. A main vessel, or you got so many vessels that are occluded that you just don't have enough area to be able to angioplasty stent. Their whole heart will be filled with metal. So you have another option. You can put in bypass grafts. You can find where these occlusions are, take a vein. You know, they sometimes use the saphenous vein. That's one. You could also use arteries. You can use the internal, like thoracic artery or the internal mammary artery. You can sometimes use like parts of the radial artery, and you can form like a graft, like a tube. So imagine here, this area was open up. Then you have the occlusion. You take that saphenous vein that you chopped up into pieces and guide it from this area where there was flow past the area of obstruction, so that when blood flow is coming through here, it can run right through the graft. And so this is called a coronary artery bypass graft. We commonly kind of put this as a cabbage. And again, this can be done with arterial grafts, so you can use an artery graft like a radial artery, or sometimes they can use the internal thoracic artery, or you can use venous grafts. These are kind of preferred, like the saphenous vein. Okay, so that's another indication. And we'll talk about what are the specific indications for why I would do a cabbage over something like a PCI. The last one, which isn't commonly utilized anymore just because of efficacy, it's not as great, and we also have potential complications and very many contraindications to it, is TPA. So imagine here we have this vessel. We give a drug, it's a clot-busting medication, you use it in strokes, and what it'll do is, you give TPA because what TPA does is it stimulates this molecule called, it's basically tissue plasminogen activator. It'll stimulate a molecule called plasmin. And plasmin will go and actually digest down all of this actual fibrin mesh to open up that actual vessel and recanalize it. Problem with that is that there's many different contraindications to thrombolysis, and it hasn't been superior to PCI, so we don't always go for this one first. It's something that you really don't want to have to do unless there's no kind of like facility with PCI nearby, which that's not too common anymore. Okay, so to summarize these three, you got PCI, cabbage, and thrombolysis. One of the things that you definitely need to know for your exam is if they say, how much time do I have when the patient walks through the door with chest pain and elevation in their ST segments, do I have before I poke the needle in, get in there, inflate the balloon into that actual occluded vessel. And the time frame that you need to know is less than or equal to 90 minutes. That is the goal for what's called door to balloon time. And again, you do an angioplasty, you stent the vessel open. This is primarily indicated again for STEMIs and STEMIs unstable angina with elevated troponins and a high TEMI score. That again, you've risk stratified, they're maxed out on max medical therapy and they're not benefiting from it. They would get it, a patient who has stable angina who has a positive stress test and greater than or equal to 70% stenosis, and they've electively decided to get a cath. These are particular reasons why someone will get it. Or they have hemodynamic instability, you'd get those caths. We use two different types of stents which may come up in your actual questions. One is called a bare metal stent, not commonly utilized as much anymore. And then the other one is what's called a drug-eluting stent. And the whole point of the drug-eluting stent is it contains a little cytostatic agent on it that is designed to be able to inhibit growth around the stent, what's called intimal hyperplasia. And so it's designed to reduce the risk of restenosis. But common complications that can happen with these stents, especially these drug-eluting stents, is they can rethrombose. So that's a high risk thing and it's something that may come up on your actual questions. This is the more commonly utilized ones. The risk for these is what's called rethrombosis. And because there is a risk of rethrombosis, they need to stay on dual antiplatelet therapy, clopidogrel and aspirin, or ticagrelor and aspirin, for at least a year. And then after that year goes by, their risk of restenosis, rethrombosis is lowered, but you should continue them on aspirin afterwards. And then hopefully, again, that prevents any risk of rethrombosis within these stents. All right? All right, so we covered PCI. Again, door to balloon time is important. Knowing the two types of stents, drug-eluting stents is more important, but to reduce the risk of rethrombosis and restenosis, You utilize dual antiplatelets for at least a year, and then after that, you use aspirin again to try to prevent any re-thrombosis. All right, CABG. What are the big reasons why I would do a CABG over a percutaneous coronary intervention? The reason I would do this is if the LAD, the left coronary artery. So you have the left coronary artery that gives way to the LAD, and then it also can give off to the left circumflex. If the left coronary, the main component, was clotted off, or it had a big thrombus in it, that's a pretty significant vessel, and that would deserve a CABG for it. Another one is if the proximal LAD was 70% or greater occluded, and you had 2 or more vessels also that were occluded, that would be an indication for a CABG. Or if you had severe chest pain, you were symptomatic, you had severe anginal chest pain, and you had 2 or 3 vessel disease, that would also be an indication. And lastly, if a person has a NSTEMI, unstable angina, or they have multiple issues with ischemic heart disease, and they've been maxed out on medical therapy and they're still refractory, that would be another indication potentially for a CABG. Okay, so CABG, again, we understand how it works. We understand the particular reasons for why we would do that. Last but not least is the thrombolysis. Thrombolysis is the least preferred. If they said, how long do you have from the moment that the person walks into the door with chest pain, gets their ST elevations, and then you need to get the needle into them to give them the IV thrombolysis, like alteplase, how much time do you have? You say less than or equal to 120 minutes. Okay, and again, the medication that we prefer to give, it's most commonly utilized, is like alteplase. However, as I said, there's many contraindications to giving TPA. You obviously have to make sure that the person isn't actively bleeding. There's no other issues with anticoagulant, so many different things. And also, the efficacy of thrombolysis is inferior to someone getting a percutaneous coronary intervention. So cardiac cath labs are very common across the world, and so generally you're most likely going to get a percutaneous coronary intervention before you get TP. The only time you would get it is if you just don't have any cardiac cath lab, you give them TPA, but still try to get them to a cath lab nearby at the nearest facility possible. So even if the person gets TPA, you still want to send them to get a cardiac cath to potentially stent open those vessels. All right, engineers, before we finish off this lecture, I want to help us to remember, again, we should have like little ways of, hopefully tricks of remembering this stuff. And so out of all of these things that we talked about, revascularization, I think we've really nailed that down, but the medical management stuff, there was a lot of stuff that I hit you guys with. One of the mnemonics that we should remember is we utilize something called MONA, BASH, C. And this is going to help us to try to be able to remember a lot of the medical management of patients who have had this ischemic heart disease. So M for morphine, O for oxygen, N for nitroglycerin, A for aspirin, B for beta blockers, A for ACE inhibitors, S for statin, H for heparin, and C is one of those P2Y12 receptor inhibitors, clopidogrel, which is one of the more commonly utilized ones. And as you would see, that pretty much covered all of these medications that we talked about. And again, don't forget the revascularization, PCI, and CABG. All right, Ninja Nerds, I hope that you guys liked this video. I hope it made sense. I tell you what, if you guys really want to understand this topic, I guarantee this will help you. Go down in the description box. We'll have a link to our website. There, we have some awesome notes, very thorough, very great illustrations to follow along during the video. Watch, continue to keep writing down things. It's going to help you guys with that repetition-based learning. So please check that out. I guarantee it'll help you. Ninja Nerds, we love you. Thank you. And as always, until next time.